I'm Rohit Adyanthaya. I work at the Valley Retina Institute in McAllen, South Texas. And I'm here today to talk as to why I think the 577 yellow laser in the micropulse mode is the optimal therapy for macular edema from retinal diseases. Now, before I talk about micropulse, I want to convince you all as to why I think laser is still very important in diabetic macular edema. In this era of anti-VEGFs, where we have to inject patients every month, especially the young diabetics, I think laser still has a great role to play. And I'm going to convince you all why I think it's so important. Now, in the recently concluded RESTORE study, which was done out of Europe, if you look at the subgroup analysis of the study, in this study what they had was they had three groups of patients with diabetic macular edema. And the first group received ranibizumab injections with sham laser. The second group received active laser with ranibizumab injections, and the third group received active laser with a sham injection. Now, when a subgroup analysis was performed in this study, there was no doubt that in patients who had a central retinal thickness of more than 400 microns, ranibizumab was better than the laser. But in patients who had a central retinal thickness of 300 microns or less, laser had similar results to the injection. In another subgroup analysis, they looked into whether the patients had previous laser before they came into the study. And in patients who had previous laser before they came into the study, if you see, the patients who received the ranibizumab did better than the patients who received both the injection and the laser. But in patients who did not have laser before they entered the study, the combination therapy worked better than the injection alone. Now, the reasoning for this is patients who already had laser and came into the study were laser failures. So instinctively, we can summarize or theorize that they would not improve with additional laser. But the patients who did not receive laser, as you can see in the study, did much better with the combination therapy. Also in the DRCR protocol I, even patients who received the injections, many of them needed laser treatment. In fact, over the 3-year period of the study, 46% of the patients who were treated with ranibizumab and deferred laser still needed laser treatment. And this is after an average of about 14 ranibizumab injections, and that roughly translates into about $30,000. Well, that was my salary as a fellow. Now, in the READ 2 study, which was done in the United States, it had a similar study pattern as the RESTORE study. Here, it was clearly demonstrated that patients who received the combination needed fewer injections than the patients who received laser alone, injections alone. Now, a brief slide on conventional laser, the traditional laser that we've been using in the ETDRS and the other studies. It's got a lot of disadvantages, and that is why micropulse is so important. Number one, it causes permanent destruction of the photoreceptors. They're dead. We burn them. Studies have shown multiple times over, there have been multiple studies which have shown that the laser scars enlarge over time and they encroach the fovea. You know, we all have had patients who are 20/20 but complain miserably that they can't see, they can't read. And when we do microperimetry studies on these patients, we see that they've lost their perimetric sensitivity. And of course, with these laser burns, there's always a risk of choroidal neovascular membrane. So let me explain what is micropulse. Basically, it's a new technology which will chop your continuous wave laser into microsecond pulses. What is the advantage of these microsecond pulses? Well, it'll allow your tissues to cool in between the laser. It'll prevent the thermal buildup. It'll restrict the photothermal effects and lower the risk of hemorrhage. Now, there are a couple of terms which are new to micropulse technology, which are, but the most important is duty cycle. This is something you'll always hear when you do micropulse, duty cycle. And what duty cycle basically is the amount of time the laser is on. Now, here, this is your traditional continuous wave laser. The duty cycle here is 100%, meaning the laser is on 100% of the times. But in micropulse, as I said, it chops the laser. So we use 5%, 10%, 15% duty cycle, and I'm going to explain which one's better. But basically, for example, if I say 10% duty cycle, what I mean is that the laser is on only for 10% of the time. And that is the advantage of micropulse, like I explained in my previous slides. Clinical applications of micropulse. There are numerous applications. Macular edema from diabetes, branch retinal vein occlusions, central retinal vein occlusions, CSR, some of them have tried it in PDR. I've had my glaucoma colleague who's using micropulse for his SLTs. Now, a quick slide on the mechanism of action of any laser. How does laser work? There are numerous theories, but one of the main theories is that it'll upregulate the intracellular biological factors. And the most common is PEDF, which is pigment epithelial derived factor, and thrombospondins. These are potent anti-angiogenic factors, and these we theorize help in the resolution of the edema. Now, animal studies have shown that 3 months after the laser, you will see TSP positive cells at the edges of the laser lesions. And what you need to get from this slide is that the effect of the laser is not from the killed or the burnt tissue, it's the surrounding area surrounding the laser which actually secretes all these anti-angiogenic factors which help in the edema. Now, this is our conventional ETDRS laser. The endpoint is a visible burn. You need to see the burn. But what happens? That burn causes cell death and finally a scar. As I explained, the response is from the heated tissue which is still viable adjacent to this dead tissue. That is what liberates your intercellular biological factors. Whereas in your micropulse, the endpoint is subvisible, meaning you do not see the burn, but the response is from that treated burn area. That is what stimulates your RPs and secretes these biological factors. The surrounding tissue is not harmed at all. So the effect on the surrounding tissue is negligible, which is one of the advantages of micropulse. I'm going to show you a couple of studies done with micropulse, randomized trials which demonstrated the efficacy of the micropulse laser. Now, this is a study that came out of Italy. They wanted to compare your traditional ETDRS laser with micropulse laser. It was a prospective randomized trial of 62 eyes with CSME. They used fundus autofluorescence, OCT, microperimetry and fluorescein during various stages of the treatment. They used the 514 green laser for the ETDRS treatment and the 810 diode laser for micropulse. Their treatment settings for the ETDRS group was similar, whereas in the micropulse group, as I said, they had the 810 laser. They used 125 micron spot size with a 5% duty cycle, and they used 750 milliwatts of power. The spots were delivered in a continuous fashion, meaning they made sure there was no space in between the spots, which is important. and they treated up to 250 microns of the foveal avascular zone. In this study, they found that the vision and the retinal thickness was equivalent in both groups. So both groups had stabilization of vision and the retinal thickness decreased equivalently in both groups. But the important and the main feature of this study is that when they did microperimetry, they found that the central retinal sensitivity actually increased in the micropulse group, which is one of the advantages of micropulse, whereas in the traditional ETDRS group it decreased. Fundus autofluorescence showed no evidence of RP damage in the micropulse group, whereas in patients who received the traditional laser did show areas of RP scarring. This is an example from that study. You see on the left, this is a patient who had the traditional laser. You can see how at the end of a year you can see these areas of RP damage from the laser, whereas you see the areas of red have actually increased from the baseline. Whereas in the subthreshold group, there are no laser scars that you see, and there's actually an increase in the amount of green, which is good on the microperimetry. The second study came out of Brazil, and here what they did was they had three groups. They had one group with the traditional ETDRS laser, the second group with micropulse but with normal density, and the third group with micropulse but high density. Now the difference between normal density and high density was that in normal density the laser burns were two width apart, just like your modified ETDRS criteria, whereas in the high density the burns were confluent, meaning there was no space in between the burns. It was a prospective randomized controlled trial for a year. There were 123 eyes enrolled. There were 42 patients in the ETDRS group, 39 in the normal density micropulse, 42 in the high density micropulse, and these patients had fluorescein and OCT before and at various stages of the study. Now, their micropulse setting were they used the A10 diode laser, and they did a test burn in the continuous wave, and then they went up 20% to do their micropulse treatment. And they had a duration of 300 milliseconds and a duty cycle of 15%. Now, this slide summarizes the results. In terms of retinal thickness, there was no difference between the high density and the ETDRS group, but what they found was the normal density micropulse group was inferior as compared to the other two groups. In terms of vision though, the high density group was better than the ETDRS and the normal density group. So basically, the thing that comes out of the study, and a very important point from this study, is that when you do your micropulse, you have to do a confluent pattern. You cannot leave space in between the spots. That is what I have also learned along the way, that it's very important you paint the area of thickening. Now, the last study I want to show you, it's a quick slide. This is from Jeff Luttrell in California. He basically wanted to see if there's any difference between the various duty cycles in micropulse, between the 5, 10 and the 15. And what he found is that the eyes which were treated with a 5% duty cycle did much better, meaning there was no evidence of laser scars or retinal damage in that group, whereas the eyes treated with the 10 and 15%, 8% of those patients showed evidence of retinal damage on microperimetry and fundus autofluorescence. Now, a couple of slides on the yellow wavelength. So I told you about the advantages of micropulse, but now we have the 577 with micropulse capability, and I want to tell you why I think the yellow wavelength, the 577 wavelength, is the optimal wavelength to use. As you can look on this graph, the 577 wavelength is on the peak of the oxyhemoglobin curve. What it means is that as compared to the other lasers, oxyhemoglobin will absorb the 577 laser the most, which is what we want, because we want the leaking vascular tissues, the microaneurysms, to absorb this laser to help in its closure. And of course, xanthophyll in the fovea is not absorbed by this laser. There's another term that we use, it's called extinction coefficient. What that means is basically it tells us how strongly a substance absorbs light at a given wavelength. And if you look at this graph here, you'll see that the 577 wavelength has the highest ratio of oxyhemoglobin to melanin extinction coefficient, which basically tells you what I said. The MAs, the vascular structures, absorb this wavelength the most, and melanin in the RPE does not get damaged by this wavelength as compared to the other lasers. It does absorb it, but to a lower extent, which is good. We don't want to damage the RPE. So besides the absorption of the yellow wavelength, there are a couple of other advantages. Since it's a higher wavelength, it will transmit better through ocular media. Say if you got a cataract, this will do better than your green laser. Also, it requires a lower power, and I have seen it because I use the conventional yellow laser when I do PDR, when I do PRP in PDR patients, and there's no doubt that patients are more comfortable with a yellow laser than with the traditional laser. Of course, like I explained, it's not absorbed by the xanthophyll in the fovea, and with the micropulse technology, you can combine the yellow laser and the micropulse. Now let's get to the fun part. How do we use micropulse in our practice? Well, it's been permutation and combinations. We've tried all different things, and finally, right now, this is what we are using. When I see a patient who's got a central retinal thickness of more than 350 microns, I will initiate anti-VEGF therapy and then inject till the thickness comes to below 350 microns, and then I will treat with my laser, with the micropulse laser. We do have a lot of patients who are on Medicaid, and it's an insurance which will not cover for anti-VEGF treatments, and laser is the only treatment we can do. For them, even if it's more than 350 microns, I will use a micropulse, but I do explain to my patients that they might need multiple sessions. There's no doubt in my mind that with this combination, the need for repeated injections has decreased. I do not have to inject patients as many times as I would if I would just give them injections. These are my treatment settings. You'll probably see various other speakers have their own treatment settings, but the way I have finally figured it down is that I do my test burn, but I do it in the micropulse mode. I always use the 5% duty cycle, and I think across the board, all the micropulse speakers have now come to a conclusion that 5% is the best and the safest duty cycle to use. I start with 600 milliwatts of micropulse power. I go to an area nasal to the optic nerve, which is not thickened, and then I start with 600 milliwatts of micropulse power. I increase by 100 millivolts of power till I get a faint burn. Now, once I get that faint burn, and usually it's around 1000 milliwatts. That's usually what I've been noticing. Once I get that test burn, I'll go down by 1/3. Meaning, if I get a test burn at 1200, I would go down to 400 as my treatment setting. Now, I of course use my fluorescein, but many times I just rely on my OCT. And what I do is, I look at the OCT, the thickness map, and the areas of thickening is what I treat. I treat it confluently, meaning no space in between the burns. I just paint that area. If there are MAs very close to the fovea, I still go and treat the fovea. But I still am not that adventurous. I still use 100 milliwatts of power on the micropulse mode within 500 microns of the fovea. And so far, I have not seen any burns. You might find some speakers who actually go higher than this, but I haven't tried more than 100 milliwatts within 500 microns of the fovea in the micropulse settings. Now, you won't see the burn, so it is very important that you focus during the laser, meaning your laser burn has to be focused on the retina. That is important. So, I'm going to present some cases. This is a young gentleman, diabetic, again on Medicaid insurance, meaning I couldn't give him anti-VEGF injections. But he was 20/80 before the laser. 3 months after the laser, you can see the difference. The retinal thickening has completely disappeared. You'll still see those hard exudates, but they will take time to go away. But beautiful results. One setting of laser. Second case, left eye. Again, similar patient. Insurance wouldn't cover anti-VEGF treatment. He was 20/60. This patient, at the end of 2 months, you can see there is almost complete resolution of the edema, and his vision is improved to 20/40 from 20/60. Third patient, again the same story, could not do anti-VEGFs. But this patient I had to do 2 sessions, meaning when I saw him back after 4 months, the edema had subsided but hadn't completely gone away. I did a second session. At the end of 6 months, fovea completely flat. Vision had improved. 54-year-old patient with non-foveal edema. She had a cataract. She has a PSC, so the cataract surgeon wanted to do the cataract surgery, but I wanted to control the edema before I sent her for the surgery. So treated her for this non-foveal thickening. At the end of 4 weeks, you see how the edema has subsided. You still see the hard exudates, but the edema has subsided. Now, in this case, I would like to show you, which was something that was interesting. As I said, I do my test burns with the micropulse, in the micropulse mode, and I usually go around the optic nerve. If you see these white spots here, those are the burns I have created by trying to create a test spot. Meaning, I've increased it slowly from 600, and then finally, I think in this patient, I got a test burn at 1800 milliwatts. But the reason it went up to 1800 is because this patient, if you notice, there's a haze and there's a PSC. So the cataract probably necessitated me to go up to a higher power. So I went to 1800. That's when I got my test burn here. And this is the fundus autofluorescence 4 months down the road. That will show you the scarring that has been caused by the test burn. So the 577, if you go very high, you will damage the RPE. So you have to titrate. It's not like your 810 diode laser, because you will have speakers who will tell you that with the 810, they go to the maximum and they don't get the burns. But in the 577, it's a longer wavelength. It's a wavelength which can produce burns, so you got to be careful. Now, this is the post laser fundus autofluorescence. This is the post laser fundus autofluorescence. I used 600 milliwatts of power. There's no burn spots that you can see. And like I showed you previously, the edema had subsided. This is the last case I have. It's a patient of central serous, young guy. I was watching him. 8 months, he still had that persistent swelling. I treated him with 1 session of laser. Within 4 weeks, fluid is completely gone. We've had many other patients with CSR who responded beautifully to Micropulse. So that is my talk. Thank you.
Excuse me. Thank you very much. And Dr. Victor Gonzalez has joined us here. Thank you for coming. And I'd like to open the floor up to any questions or comments that you have for either physician. 1 moment, please. I'll bring over the microphone so everyone can hear you as well, and give them a chance to put on the headset. Okay.
I have a question. Hi, Victor. How are you doing? A question is, sometimes when I use in this laser, there are different pigmentation at the fundus, and this may be a problem, especially in albinoid fundus. What is your experience about that?
No, I agree with you, and you know, the ocular media, the pigmentation, they'll all determine the power settings. That is why I always go with Micropulse as my test burn, and then accordingly I will alter my treatment patterns. I agree with you. Yes.
One of the other ways I handle that is that, as he pointed out to you, sometimes you'll get effect in certain areas and not in others, and it may be something like that. The beauty of it is you can always come back and treat them later on. So, even if you don't get, if you do have that type of difference in pigmentation across the fundus, try and be consistent with your treatment. You can always come back and apply some more treatment in the area if it doesn't resolve. So, and the beauty, as he showed you in that autofluorescence, is that you do not cause, if you use it correctly in the way it was described, you do not cause any irreversible damage to the tissues. I don't know if you had an opportunity to be at the Jackson lecture this morning, but Mark Blumenkrantz, who is probably one of the leading experts currently in lasers, gave a lecture on lasers and the history, and he's done a lot of work on micropulse, as a matter of fact, and he showed these beautiful slides that demonstrated that if you cause just light thermal injury to the tissue, he's been able to demonstrate that the retina can heal itself. So, even if you do have a very light burn, the retina has the capability of repairing itself, and that's the beauty with this. We think what's happening here is actually we're not causing, obviously an irreversible damage. Somehow that is playing with the biochemistry of the RPE. The RPE is very important in terms of producing VEGF and other factors. I mean, it's on the apical side, on the base of it. It produces VEGF in order to keep the fenestrations from the chora capillaris. So the thing that drives that is ischemia. So the more ischemia the retina is, the more VEGF is produced, because you want those valves open and you want the oxygenation and the nutrients coming through those fenestrations. On the apical side, it produces VEGF to try and maintain the cells. So it's more of a stabilizer of the cells. So VEGF is the RP is a VEGF pump, and I think the micropulse somehow is altering that. And currently we're setting up some studies to try and do some proteonic evaluation of the different cytokines and chemokines in these patients to try and see if we can figure out exactly what it is. Bottom line, as Dr. Rohit told you here, we do not know yet exactly what's happening. The interesting thing is that it works.
One more question. As you use this protocol, are you worried sometimes in cause injury to the photoreceptors at the subfoveal laser? Because one of the principles of the treatment is to be confluent. Have you observed some damage in any cases you perform this kind of treatment?
Using these parameters up to now, I have not seen any damage. I rarely use very high energies. What I will do, and we've got some protocols that are evaluating this. I will, if there's really significant thickness in the macula, okay, at baseline, what I will do is I will give them 1 or 2 anti-VEGFs just to dry up the macula, and that gives me an opportunity to significantly reduce the amount of energy that I need. And I unlike my other sources, I will treat subfoveal if it's significant, and I have not demonstrated any significant changes on autofluorescence using that.
And again, if you, at least when I do it within 500 microns of the fovea, I would not go, with my settings for the remaining fovea. I just treat with 100 milliwatts of micropulse power, which is significantly lower than what I'm treating the remaining.
So whenever I'm going to go subfoveal, what I do is I'll use non-micropulse, and I'll do a little burn. And then whatever that energy is, just to get a very light burn, I go to micropulse. So usually it's as he said, it's somewhere between 70 to 100 milliwatts. So it's very minimal. I mean, I really do think what we're doing here is light therapy. It's not a photocoagulative effect what we're doing here. It really is light therapy, and somehow that's giving us the results that you've seen.
Photostimulation.
From using 810 nanometer laser, and now you've shown us some nice clinical pictures using 577. I didn't quite follow the logic of why you went from 810 to 577. The 810 seemed to work. You got scientific data showing it does work. Why have you changed over?
Well, it's because of the wavelength. Because when I looked over the
Yeah,
wavelength,
clearly it's the wavelength,
Correct.
and you're trying to influence the RPE here, trying to get some influence in the RPE. 810 nanometer is beautifully absorbed there by melanin. So why go to 577? It didn't seem to be logical to go to an oxygenated hemoglobin level.
The reason you want to try and do that is that he showed you the difference in absorption between, you know, the pigmented tissues. Yeah, but he showed you you know, what you don't want to heat. You don't want anything that's going to be very efficient at heating the RPE. Okay, and 577 is less absorbed by the RPE than the 810. Okay, because the whole idea here is not to cause a thermal change. Okay.
Shown us clinical papers which have had used 810 nanometer, and that it was working. Yeah, you've shown us an effect, and you've got clinical data showing an effect with 810, but you know you're now using 577, and why the change? There doesn't seem to be any logic behind changing.
Well, there are a couple of reasons why I've changed over. I mean, if you've done PRP with an 810 laser, the patients feel it more. Okay, there's a lot more pain. Okay, you know, so you know, yes, you know what we're starting to do now is also use the micropulse for PRP. Okay, and I think one of the reasons initially had been was that there was a comfort difference there. I think your point's a good one. You know, the bottom line is that, you know, if you heat up the RPE in the right way, I think 810 and 577 works as well. Okay, the difference is that, you know, the 577 tends to have less absorption in the RPE itself because of that coefficient that he showed you. But it both work. If that's yeah. You know, right now we're setting up some national trials. You know, because these are all anecdotal, you know, small case series. You know, what Dr. Rohit's doing right now is he's setting up a large multi-clinical national trial where we'll look, and we'll look at you know, randomizing these patients and actually see, you know, if that benefit is held in a much broader, bigger setting. Yeah, so he's heading that.
You showed the case of CSC, and I have the experience of micropulse treated with in the patient of CSC. And what do you think the mechanism of the resolution of the subretinal fluid in CSC? Because the micropulse does not create burn at the area of the RP tissue. The mechanism of resolution of fluid of CSC is closing the micro hole in the RPE. So how do you explain the mechanism of resolution of fluid in the case of CSC?
I think it's like you mentioned, it's photostimulation. I think it's stimulating the RPE to reabsorb the fluid. So I think that is what it's doing, and that's what it's doing across the board for all these diseases.
Do you put the laser? Do you apply the laser at the leaking point, right?
No. So like
entire
no
macula?
For this patient that I did the micropulse, I just treated this area which was leaking. This. I mean,
the area of the RP detachment, right?
Just the area of hyperfluorescence on the fluorescein. I just treated that area.
RP detachment.
Correct.
Yeah.
Just that area. I didn't paint the entire.
Not entire the retina.
I did not.
No.
I did not.
So I cannot understand the mechanism of the.
Right. You know, I don't think we could ever understand how lasers and DME ever works. You know, the bottom line is it does work. You know, and I think the reason is that we don't have a really good way to do some local, you know, biochemical analyses. But I think the proteomics that we're proposing, you know, we've developed a technique to be able to do in-office vitreous biopsies in some of these students under these subjects, under, of course, IRB approval and so forth. And hopefully that's going to give us some guidance as to what's happening. But I agree with you. I mean, I don't think everybody 100% understands why it works. Just like when we had the original ETDRS results with lasers, everybody thinks it's just going straight for the microaneurysms, but as you know, that's not what we were doing. We were laying down grids, and we weren't quite often not causing blanching of microaneurysms, but that worked. Somehow the laser is causing a change locally in the biochemistry of what the VEGF, the RPE is doing. Because there's no doubt that, at least in DME and in diabetes, the VEGF is very important. You can cause a lot of those vascular changes in a non-diabetic animal just by injecting the vitreous with VEGF. The dilated, tortuous vessels, the leaky, the microaneurysms, all that can happen without, hyperglycemia, just with the VEGF. So the VEGF is very important, and we think that the laser is having an impact there. Now in CSR, no one understands even what the cause of CSR is. The interesting thing is that this observation that has been presented, has been repeatable multiple times within our patients, and other centers have also reported this.
Do you change the parameter when you do the laser of CSC?
No, I don't.
The same parameter.
Same.
So
That's what I've been using.
We have another question back here. Just a moment.
You just said that you don't treat the area of leak, but isn't that what is shown on the angiogram there, that you're treating?
No, I said I treat the area of the leak. I treat the area of the leakage.
So you treat the area of leakage, so you're basically treating the rip in the RPE, which is the same as thermal laser.
I'm sorry, can you repeat that?
I said you're treating the area of leak,
Correct.
which means you're treating the break in the RPE, which is exactly the same as treating with the thermal laser.
But it's not as strong as your thermal laser. So we are postulating that this stimulation is just going to stimulate the RPE, photostimulate the RPE, not photoburn the RPE. So it's not photo disruption, it's photostimulation.
See, one of the other things that he's talking about here is that, and I think that was the question, do you treat the whole area of the serous detachment? No. The only area you treat is the area that lights up on your
Sure,
fluorescein.
but if you use thermal laser, you're not treating the whole area either. You're only
Correct.
treating this.
But you're having
you're pinpointing just the spot of leak with your thermal laser.
That's correct, but you're not. The difference is that you're not causing photocoagulation. You're not having the protein in that area disrupted like you do thermally with the micropulse. You don't see an effect there. If you do thermal laser and a CSR lesion, you'll actually see whitening of the area. And if you look at it histologically, the whitening in the area is the fact that the retina has been coagulated in that and destroyed in that zone. With this, you don't do that. If you look at the OCT before and after you apply the laser, you won't see any disruption in the retinal tissue itself. So yes, we're applying it exactly as if we were treating thermally with a thermal laser, but we're not using the energy to cause a burn.
And how quick is the resolution of the CSR?
This was 4 weeks. This was in 4 weeks.
Well, with thermal laser, you can see resolution probably within a week.
This patient, I saw him back in 4 weeks. I don't know if I'd seen him back in a week, I would have got this result, but I saw him back in 4 weeks.
The difference is this, look, with a thermal laser, you're going to get a scotoma. With a micropulse, the microperimetry is basically near normal. And that's the whole idea, right? You want to cause resolution of the pathology without irreversible damage to the tissues.
Gonzalez, asking you about PDR and PRP. How does it work? What happens if you need to repeat it, the PRP, etc.?
Well, that's what we don't quite understand yet. I mean, yeah, the answer is yes. You can repeat. You can repeat it, and that's a little bit more of a challenging protocol right now. Okay, I think again you're going to read about it. It's very anecdotal. We don't quite understand why it works, but in some of these subjects, if you treat enough of the area, it works. And it can cause resolution. So obviously, we're causing some type of biochemical change. If you know the microenvironment in the in the eye with PDR, most of it is VEGF, but it's not only VEGF. There's some important inflammatory cytokines, IL-6, interleukin-8, some of the ICAM. Those type of chemicals can be very important in causing a lot of the pathology. Again, we just have ways to be able to analyze this. And our group is going to do analysis not only, of course, with the laser, but we have some protocols where we're looking at the different anti-VEGF agents. We're taking baseline profiles, we're suppressing them with these drugs, and then we're taking intermittent samples of the vitreous to see what happened to these inflammatory profiles, and hopefully that'll help us understand your question. But the bottom line is that even an expert like Mark Blumenkamp, who's been working with lasers all the time, can't tell you exactly why and how lasers work. So much less someone like me. He's got much more experience.
Excuse me. One more question over here.
May I ask what type of laser setting? What was the power you used on the 577 micropulse?
So let me show you what I do is I do my test burn with the micropulse, and once I get a test burn, I go down by 1/3 of the test burn, and then I do my laser.
Yeah, that's why in that one case, if you notice,
Usually, what is your normal power setting somewhere?
5% duty cycle,
5% duty cycle.
200 milliseconds duration, and a spot size of 200 microns.
Do you have any data to support that?
Well,
Those settings?
we haven't done a proper trial, but we are in the process of writing a trial.
Okay, have you done this with the 810 micropulse?
No, we haven't done it with the 810.
And the reason for that?
Is because right now I think the wavelength is better, and we have the 577 machine with us. That's why.
Do you have an 810?
No, we don't have the 810.
Okay, that's probably the main reason then.
well, I do.
You have
And
810,
I
okay.
have 810, and I don't use it. I use it primarily for ROP now. But as part of the bigger trial, I think one of the things that we need to do is, we need to do a couple of things in this trial, and that's why the protocol has been taking a little time to get going. We're going to probably potentially look at different wavelengths to see if there's any interest. Everybody's used this particular protocol, but I can tell you that I've had some resolution with even some lower, energy settings. Again, it's all anecdotal right now, but I think a large clinical trial like the one that's being designed is going to help us, understand this a little better. Because your questions are a good one. Do I think the 810 works? I think it does.
810 does work. Because I've
think
done it with
it does.
810. I have an 810 myself, micropulse, but I don't have a 577, so I don't know if there's a difference. But you're familiar with DARPA, the defense agency. They did do the studies. The National Defense Agency. They did the research on the space on the low energy wavelengths. Okay, basically they found that the lower wavelengths, longer wavelengths, between 600 and 1,000, have a healing effect on human tissue, and they used it on the space station because in a no gravity state, it's very difficult for cells to heal. So they use lasers to enhance healing. So they found that it increased multiple mechanisms at the cellular level. Longer wavelengths, low energy. The energy they used was 4 millijoules per square centimeter. So I don't know what kind of power setting you had equivalent to 4 millijoules, because that depends on the number of pulses you used, right? So you multiply by the number of pulses, you get the power times the power times the number of seconds, right? The energy times the number of seconds gives you the power. So if you're using energy at 4 millijoules per square centimeter, theoretic or less, because they showed that high energy is definitely destructive. There's no question. Any wavelength, any laser is destructive. But low wavelength, lower power is actually healing effect. So that's what you're talking about. And there was these studies that came out where you have increase in TSP1 and PEDF, okay? And they're both increased with micropulse laser, and they're both anti-vasogenic.
Right. He
Exactly.
talked about
Yeah,
that.
I
correct,
spoke
right?
about that. Yes.
So that's probably the mechanism. Because you're increasing, because right now you're talking about a state of the eye where you have increased VEGF, theoretically. experimentally. So you're increasing those the other elements, the other cytokines or the other chemicals that are naturally released in the eye with the micropulse. Somehow you're increasing it. Is that correct?
Correct.
So
Right.
isn't that theoretically the mechanism?
Well, theoretically, yes.
Yes.
And but hopefully we'll be able to demonstrate
Sorry,
that with some of the the profile, the cytokine and chemokine profile studies that we'll be doing as part of the
So wouldn't
national
this work for
trial.
macular degeneration then?
Well,
Subfoveal
that's
lesion.
you know
we're talking about non-scarring laser, correct?
You know what? It's funny you say that, but I'm actually setting up a sub-analysis to to try and do that in some of these patients, especially some of the ones that have been non-responding to anti-VEGF therapy. I'll continue the anti-VEGF therapy, but I'm going to consider doing an IRB approved protocol for this as an adjunct to see if it works.
But you're going to use 577, not the longer wavelengths.
Well,
Because
we
other
may
studies show that the longer wavelengths are actually beneficial. They're actually healing. They have actually effects on, they increase the oxidative metabolism of mitochondria, increase gene expression, et cetera, according to all the DARPA studies.
Yeah, and at one of the centers where we're going to be doing this, we do have access to both wavelengths. So we're looking at both. There's actually three. Even the 532, some people are using the 532 micropulse. My main interest is 577 and the 810. For the reason, I'll tell you, it's a funny story. I first was introduced to light treatment actually through my vet. My dog had some thing going on with its neck, and and I went over there, and the guy says, well, there's this light treatment because the dog was not getting better. There's this therapy, it's going to cost you this much, but it seems to work. And I was going, and then I said, well, go ahead, because my wife obviously was pressuring me to do this, and he did this therapy, and amazingly, it's amazing. So I agree with you, and I think they were using, a red wavelength. I don't know what it was.
Well, they've been doing light therapy for over 100 years, okay? And they found specific wavelengths, and one of them is two of them actually are in the infrared range.
Yeah.
That are actually found to be beneficial. They're very specific, those wavelengths, that are beneficial to cells. And theoretically, they cause the cells to rejuvenate themselves. They even market these things, these light therapy things. So it's really, they've been doing more than 100 years.
Oh, yeah, no, I've seen it. Yeah. Any other questions? We're good. Well, thanks a lot. Thanks for your attention.